Finishing up with coagulation disorder pathologies, we'll go over some pretty straightforward bleeding disorders, beginning with small vessel abnormalities, abnormalities with platelet function. There's coagulation factor deficiencies, and then there is the DIC, disseminated intravascular coagulation cascade. That is also referred to as death is coming in some clinical circles. So you should know that that's really, really dangerous, and it's definitely not advantageous for patients. Okay, whoa, okay. So we are going to start out with small vessel abnormalities. So just for your own knowledge, as you get older, blood vessels do lose some of their integrity. So this could be something that somebody just has easily bruising tissues because they have more delicate vessels. There's also malformations that occur in a genetic sense with small vessels not being created in the appropriate physiologic way. Then there is the final case where it says defective constriction leading to bleeding. If there are patients that are on very strong vasodilator substances like nitroglycerin, those can cause so much vasodilation that the blood vessels aren't able to constrict as they normally would in initial injury, and that will lead to abnormal bleeding. So just keep that in mind with things that are vasodilating in nature. They can make blood vessel function abnormal. The other disorders are pretty straightforward. We'll start out with thrombocytopenia. Penia means deficiency in. Cyto is cell, and thrombo is clot. And we know thrombocytes are platelets. So thrombocytopenia is referring to a deficiency of platelets. When there are just normal little injuries to blood vessels that happens all of the time, just when blood pressure goes up and shear stress increases, platelets are there to seal up the initial site of injury, forming a platelet plug so that there's not extensive bleeding. If there is a deficiency in platelets, you will see that there are a clinical sign that pops up called Petechial. So this is Petechial. I'll make this really big for you for just a second. Petechial are these little pinpoint bleeds, and they almost look like a rash, but essentially what you're looking at are small areas of bleeding where there weren't sufficient platelets to form the initial platelet plug and make the platelets seal in just normal cases of blood vessel damage. When Petechial are larger, they're referred to as purpura. So this is purpura. Purpura are larger Petechial. So these are also bleeds. They might resemble bruises, but what makes it more clinically relevant for you to distinguish between them, Petechial and purpura don't blanch. That means when you put your finger on these pieces of darkening of tissue and press into them, they don't turn pale as typical tissue would. So you don't see capillary refill. They're dark and they remain dark. When there is a continual bleed, these are two cases of continual bleeding for you to take a look at. So here is a continual bleed in the colon. So you might remember from the cancer chapter that GI bleeding is really prominent in colon cancer. So if there was a tumor that necrosed and was continually bleeding, you'll see that platelets run out in that area, and you'll observe as a pathologist Petechial in that area. You can also see this in a brain. So here is coronal tissue in the white matter. You see these little Petechial stains. So those little pink dots are an indicator that there was a continual bleed, which led to a deficiency of platelets in that local area, which is probably why there was such a large subdermal hematoma in this individual. This is called a hemorrhagic stroke. There were two of them here. And these Petechial lesions, they would tell you as a pathologist, as anybody examining the tissue, that this was something long-standing, which was evident by the presence of the Petechial. The symptoms of thrombocytopenia, because there's not adequate platelets to begin the coagulation cascade, you'll see more bleeding into tissues. So that's bruising, nosebleeds. If you think about when your nose bleeds, it's usually when it's really dry or there's a damage to the nose. So if the nose is bleeding continually, that could be a sign of thrombocytopenia. And then again, what presents as a rash, but is really this petechial, showing you that platelet sealing is not occurring. So tests that you can do when somebody presents with signs like petechial and purpura, and you might expect these if somebody's on aspirin and or Plavix. When somebody has a stroke, you'll see them on both of those as a more aggressive treatment. So you might want to do a complete blood count, CBC, and you would see a low platelet count in the CBC. You could do a bone marrow biopsy looking for the precursor cells to platelets to see if they're being created in the correct way in the bone marrow. There's also different autoimmune causes of thrombocytopenia. So you can do a blood test looking for the antibody associated with platelets, because in this autoimmune disorder, there's antibodies created to healthy platelets so that the immune cells in the body start to clear them from the circulation. So then, depending on the cause of thrombocytopenia, you'd have to treat it depending upon what the cause is. So if it's the autoimmune cause, then you would want to give immunosuppressive drugs. If it is truly just the bone marrow are not creating it, anaplasia, so lack of creation, lack of making, you would give blood transfusions to that patient. If you don't treat appropriately, the complications, which means how can it kill you, are intracranial bleeding, like you see here in B, GI bleeding, like you see in A, and then continual nosebleeds, which if you've ever had a nosebleed before, you know that they can bleed quite a bit, so you can have quite a fair amount of blood that's lost in that case. Okay, so just to review, in thrombocytopenia, we're going to see more of these pinpoint style petechial, which is going to be indicative of low platelet level. Whenever you see low of anything, penia is the word root that you'll see used to describe that. So thrombocytopenia, very characteristic petechial hemorrhages. So that indicates that there's not enough platelets available for sealing in just normal cases of stress to the vessels. So I want you to notice these pinpoint rashes and then contrast that with these really large hematomas associated with plasma coagulation factor deficiencies. So deficiencies of platelets is going to give you a pinpoint-like rash, whereas deficiency of a coagulation factor is going to lead to very, very extensive bleeding and darkening of the tissues. So these fall into a couple of different groups. The first is probably the most well recognized, the hemophilias. So there's two recognized clinical types of hemophilia, and one way for you to remember these is that they are X-linked. So that means that you can see that females, because they have two X's, they can carry the recessive gene for this, but females themselves cannot express hemophilia. Only males can be actively hemophilic. So if you're looking at patients and they have bleeding abnormalities, you generally want to rule out a hemophilia if it's a female or estrogen dependent. So in a male, they have an X chromosome, obviously, but they have to have the ability to pass that on to a son to have the active hemophilia. So there's two types of recognized hemophilias. There's hemophilia A, and I want you to say A, like A, because hemophilia A is a deficiency of factor 8. This is called classic hemophilia because it's the most common type. In the cases of hemophilia A, if somebody has elective surgery, especially dental surgery coming up, they will be given prepared factor 8 to prevent bleeding crises. The less common type, but still one of the two categories of hemophilias, is hemophilia B. It's called Christmas disease, not for the holiday, but after the first patient to exhibit it. Hemophilia B is a deficiency of factor 9. So in the same way, if somebody with hemophilia B was going to receive elective surgery, dental surgery, they would receive prepared factor IX to try to limit the bleeding. And if you remember from the coagulation cascade, both 8 and 9 are later on in the cascade and help lead to the activation of factor 10 and the final common pathway. So females have 2 copies of their X's, but they can carry the gene. Again, females can't express it. So you only see expression of active hemophilia in males. And when there is hemophilia, there are very serious bleeding threats. If you think about fibrin as a sweater, if your sweater is a rainbow, so it has Roy G. Biv on it, all those colors are needed to make a sweater that keeps you warm. A hemophilia would be a lack of one of those colors, so there'd be no red or no blue. So you're still going to have a sweater, there's just going to be lots of holes in it. So that's what happens in hemophilia. There's not a really strong fibrin net. There are pieces of fibrin, so eventually you're going to see that clotting does occur, but it lasts a lot longer than an individual without an active hemophilia. So even minor surgeries, when the dentist is picking away at your teeth with their hook, that creates a huge bleeding risk for individuals with hemophilia. One of the reasons that weight-bearing exercise is good for your bone strength is when you do things like run or go upstairs, your bones knock together and it causes little micro breaks in the bone and a small amount of bleeding, which leads to the creation of new bone, which is stronger, and you get strong bone over time, and we consider it healthy. In somebody with hemophilia, when there is continual weight-bearing exercise, that those micro breaks and the small amount of bleeding, they can leak into the articular tissue. And the articular tissue is already very acidic and not a happy place for things to end up. When you add blood to it, that can cause physical abnormalities in the bone to the level where the bones actually fuse together. And that will limit extension and flexion. So another case where you might see really evident joint abnormalities from the outside are rheumatoid arthritis. And with rheumatoid arthritis, the rule is that it's bilateral. So if one knee is affected, the other one is. If one wrist is affected, the other one is. So if you just see one joint affected and you see a positive family history for bleeding disorders, you might consider the diagnosis of hemophilia. And then finally, you have a phase 1 deficiency, again, the first phase of coagulation, so from injury to the formation of the clot, so until the tissue factor, von Willebrand's disease. So as you hopefully know, when the vessel is torn and exposed to air, one of the things that's expressed by the vessel besides tissue factor is von Willebrand factor. Von Willebrand factor binds platelets. In von Willebrand's disease, there's an inability to express von Willebrand factor. So if there's no VWF, there's no place for platelets to bind. And if platelets can't start the coagulation cascade, then you're going to see a huge, huge amount of bleeding. This is extremely excessive bleeding because of the interaction of platelets with the coagulation cascade. VWF, low expression, also correlates with low factor 8. The difference is with hemophilia A, you'll only see low factor 8. With von Willebrand's disease, you'll see both low VWF and low factor 8. Very excessive bleeding. You're not going to see it in joints for von Willebrand's, but you will see large amounts of GI bleeding. They are recurrent. And in females, there is the presence of menorrhagia, which refers to very heavy menstruation. In a typical menstrual cycle, you'll see women lose 3 to 5 tablespoons of blood over about 5 to 7 days. Menorrhagia is a larger amount of blood and can lead to anemia. So von Willebrand's disease can be expressed by either men or women. It is an autosomal dominant pattern. So if there's 2 copies of the affected gene, then it will be a very strong expression of von Willebrand. So way more GI bleeding and heavier periods. Okay, then phase 2 deficiencies. Phase 2 is only the conversion of prothrombin into thrombin, and that conversion is going to require the active liver and the intake of vitamin K. So if you do a bleeding time test and you find that their phase 2 is affected, so it's ineffective cleaving prothrombin into thrombin, it's generally going to point to something coagulation factor related. So that could be because of liver damage. The factors are produced there. So if the liver is not working appropriately, that could be a cause. Vitamin K can be low in intake. Vitamin K is also synthesized into its active components for coagulation factor creation by the microbiome, by intestinal bacteria. So in cases where there's a disturbance of the microbiome, you can see vitamin K abnormalities. The final thing, liver related, is that bile needs to be created for vitamin K to be adequately absorbed. If the liver is damaged, it won't be making bile. If there is a blockage in the bile duct, like by a gallstone or a tumor, and there's no bile outflow, vitamin K can't be absorbed from the intestines into the bloodstream. So phase 2 really just requires a healthy liver and then the adequate intake of vitamin K. Said when patients are on drugs that interrupt the ability of the body to form a clot, they will hopefully receive regular testing to ensure that they have the ability to form a clot and that their drugs are the appropriate level of dosage that's needed. There are a few drugs that are truly anticoagulative in that they block the coagulation cascade. Those two are warfarin, which is sold as heparin. Warfarin, which is sold as Coumadin. Heparin is something we make in our own bodies, and it limits the ability to clot. Those are the only anticoagulative. Warfarin is competitive with vitamin K so that you cannot create coagulation factors at the same level. So if there's less coagulation factors, there's less fibrin and less clotting. So that would be something given to somebody who has a very high risk of infarct, stroke, heart attack. Heparin is something that is sold in units, and it's typically added to IV bags, and it's given by injection. So that would prevent clotting in a hospital setting when used appropriately. And then in your own body, heparin is used to block coagulation cascade when necessary. So those are anticoagulants, and individuals on warfarin receive very regular testing of their bleeding times and their ability to clot to be sure that their dose is appropriate. Okay, I'm going to add an N here because we've already mentioned the drug streptokinase, and then there's also drugs that are the same thing, which is prepared plasmin, urokinase and alteplase. Streptokinase, remember, is the most common prepared form of plasmin, and plasmin in our own bodies binds to fibrin and dissolves it so that all of the elements trapped by the fibrin are able to be liberated and then the clot dissolved. So those drugs are called fibrinolytic. So those would be, again, they're part of the clot buster regimen that's given to patients to help dissolve the fibrin and liberate the clot. Then there are antiplatelet drugs that prevent the ability of platelets to have a party so that they can't bind together and aggregate and activate more friends. So things like aspirin or ibuprofen, naproxen, those limit thromboxane production. The less thromboxane there is, the less ability for platelets to aggregate, and then there's reduced thrombosis. So when you're doing these tests, those are looking at these later stages of coagulation. So not so much the ability of the body to initially make a clot, but the later stages where there are different required steps by the body to form these different elements. Okay, again, different vitamin K disturbances that might cause phase 2 abnormalities would either be inadequate synthesis of vitamin K. You can see this with really prolonged antibiotic use. So when patients are on chronic antibiotics, that does kill good and bad bacteria, and you need the microbiome to create vitamin K. So we discourage prolonged antibiotic use or non-necessary antibiotic use to preserve the microbiome and its ability to create coagulation factors. Again, inadequate absorption could be due to blockage of the bile duct. So the liver makes bile and it flows out through the common bile duct. That can be blocked either by a gallstone that's impacted in the ampulla of Vater or from a liver tumor that's now blocked outflow. You also see vitamin K disturbances in severe liver disease where the liver is damaged, the liver cells are no longer able to make vitamin K, and this is common in cases of cirrhosis where the active liver tissue is replaced by scar tissue. And you'll see cirrhosis, which describes that case, most commonly associated with really heavy levels of alcohol consumption and alcoholism. Okay, the final thing in coagulation disorders, again, this is DIC, death is coming. It's a really severe problematic disorder, disseminated, which means all over, intravascular, within vessels, coagulation, which is clotting, syndrome. So this is when there's a huge amount of bleeding and the coagulation cascade becomes activated. This can happen in the case of shock, infection, tissue necrosis, most specifically in the case of a retained fetus. If there isn't a successful miscarriage, then that's necrosed tissue. And organs are really, really, really high in tissue factor. So in cases of shock, it's just blood not getting to an organ or infection damage to an organ. When that tissue starts to die, it releases tissue factor. That means there's going to be widespread clotting in the body. So these products of tissue necrosis and then thromboplastic materials, our tissue factors, they're going to enter the general circulation. So there's going to be a huge amount of energy put into forming very large clots all throughout the body. It's going to deplete platelets, deplete coagulation factors because it's everywhere and it's widespread. In hospitals, fibrinolysin is released to dissolve widespread clots so that there's no lethal obstruction. If this is not treated appropriately, the net effect is really severe hemorrhage. Individuals can lose a third of their blood volume within a couple of minutes. This is commonly seen if you think about working in a hospital. You would most often see this in the maternity wing because when the placenta comes off, that's a huge open, essentially gash that's now bleeding and has to clot. If there's not appropriate control and there's the release of tissue factor, then there's widespread clotting. If you've ever read about the Black Plague, the bubonic plague, where people's noses and fingers turn black, that's because of overactivation of tissue factor. There was organ death, and then there was disseminated intravascular coagulation. If those clots don't dissolve and they stay there, there's limited blood flow to those tissues, and then you see ischemia and death of the tissues. So it's a really terrible kind of feedback loop where there's an unnatural activation of clotting and the creation of clots. And then the body's like, oh no, we've made too many clots. Things aren't getting the blood that they need. So then there's widespread lysis of those clots or breakdown of the clots. So the fibrinogen is degraded. The platelet factors are already gone, so we can't form more clots. So the end result is just bleeding, really severe bleeding. So intravascular disseminated coagulation, it's really dangerous. Again, DIC, also referred to as death is coming. It's widespread clotting throughout the system, and then the body tries to save itself by dissolving those clots, which just means you have no ability to clot and then widespread hemorrhage. So it's a very dangerous condition, and we try to control for it the best that we can. Okay, finally, the lab tests for bleeding disorders. The first ones are simple. Platelet count is doing a blood draw, spinning down that blood, and then doing an assessment of how many platelets are there. So that will give you an idea of platelet count. There's bleeding time tests where a lance is used to make a small cut, and then there's a timer to see how long it takes for the bleeding to stop. And then this white piece of paper here is used to determine the spread of the bleeding. So this can be compared with averages for age and conditions to see if this is exaggerated bleeding time and exaggerated blood spread. And then there are the laboratory tests that are going to look at in tube, essentially, times to clot. So here we have coagulated blood, so it's started to form into a clot, and then we have blood that has not. So these clotting time tests, they're going to fall into a couple of different categories which help to determine whether or not it's the first phase or the second or third phase or abnormalities. So the first one is partial thromboplastin time PTT test. So that's when you would take a blood draw from a patient, you add some calcium, and you see how long it takes for it to clot, because you need calcium with tissue factor to form the initial coagulation. So that measures to see if it's a first phase coagulation disorder. So that would be things like hemophilia, von Willebrand's, all those disorders we talked about are first phase. If it's a later phase, you would normally see this with medications. It's a prothrombin time, a PT test. So in this case, blood plasma is tested for its ability to clot, and the laboratory technician physically adds tissue factor. They add thromboplastin. So then you see how long it takes for that blood in the tube with tissue factor in it to clot. So this looks at the second and third phase, because this is only the ability to cleave those substances of prothrombin into thrombin and fibrinogen into fibrin. If these times are longer, that means there's an abnormality. When people are on things, Coumadin or warfarin is the generic name, typically 2 times a week they're going to get a prothrombin time test done to be sure that their blood is coagulating appropriately so that they can live, so that they can do normal things and not die. So these are usually medication effects. Phase 2 is our warfarin. Phase 3 would be things like our streptokinase or fibrin-related effects. All the other pathologies, we're going to use the partial thromboplastin time test, so how long it takes to form tissue factor. And with that being said, I will let you read this question, and we will talk about the answer for that in class.